nursing home with hospice, things before. I didn't.
Yeah.
Exactly. I guess usually. Morning, y'all. We are here for another day in the life, and today is Friday, May 15th, and today I'm on my inpatient palliative care team. However, I decided to pick up a day for the hospice team. And the reason why I am doing that is because next week I'm just going to be on hospice completely throughout the week. And I wanted to get a little bit of a feel for what's going to be happening next week. The benefit of reaching the end of my fellowship is that I kind of get to be a little bit flexible in terms of my learning and some of my priorities. For me, I'm going to be doing both, or actually all three, inpatient palliative care attending, outpatient palliative care attending in the cancer center. So I'll be specifically seeing cancer patients. And then I'm also going to be doing the hospice program, which is also an outpatient and an inpatient hospice. I'm going to put on my sunglasses because it's kind of bright right now. So I got a little bit of a heads up from our medical director from the hospice team, and for our hospice IDTs, which are interdisciplinary team meetings, we meet with the doctors, which is going to be myself today. We meet with the social workers, so there's going to be like 2 there. We also meet with the nurses that are kind of like our eyes and ears on the field that go to see our patients that are doing home with hospice or nursing home with hospice, things like that. And then we also meet with the home health aides who kind of show up to the patients' houses and help them, like kind of bathe them, do things around the home. And then we also have some other people there as well, such as the pharmacist, to kind of help us determine whether or not we are doing the appropriate dosages or if we need to make any dose adjustments to the medications that our patients that are on. So we usually do legally with Medicare, you actually have to do meetings on a bi-weekly basis for each patient. Every week we do them, but we have to talk about a patient every 14 to 15 days. It's really, really dusty right now. This is a huge car in front of me. But we have to talk about each patient every 14 to 15 days because we have to make sure that we are not only certifying them for them to be actually hospice eligible, but we actually like to talk about how they're doing, seeing if they're having any sort of like symptoms that aren't being managed well, if they need to have any sort of family meeting to discuss any sort of goals of care. We do that pretty frequently. That way we can actually determine whether or not we need to do any interventions or see them a little bit more frequently than we are used to seeing them. So today, we usually get in there, we have our meeting that starts around like 8:30. And then at 8:30, the nurses and all of them kind of divvy up the patients and kind of do a little bit of like some managerial kind of like overhead stuff. And the doctor's input, which is going to be me, doesn't really happen until much later when they start presenting the cases and talk about things that are either happening with the patients. If they have any questions for the doctor, they just ask me and we kind of come up with a plan in the moment. And then we actually have some follow-up steps for later on down the line to see how that plan actually went. So if you guys aren't aware, the fentanyl patches are being used for cancer pain, and we usually use fentanyl patches or just patches in general whenever people have issues swallowing, they have like issues with their kidneys, because a lot of the opioids that we use, such as morphine, Dilaudid, things like that, they are cleared through the kidneys, and if your kidneys are not working properly, then we can't really use those medications because the metabolites or the breakdown products of those medications end up kind of accumulating in the system and can cause issues such as myoclonus, which is like jerking movements, and if really bad can lead to seizures. So we really have to use other medications such as methadone, which is something that you can use in renal dysfunction, or fentanyl patches, which you can use in renal dysfunction as well. So sometimes people, if they have that issue or swallowing issues, or if they're older, then they choose to do fentanyl patches to kind of help them manage their pain. But in the United States, there's the fentanyl-free America and a lot of misconceptions around fentanyl, and a lot of people that are overdosing on fentanyl. But that is people that are using fentanyl for illicit reasons and not actual legit reasons. So patients that have cancer pain, that's a legit reason to have to use opioids, and oftentimes will have to be fentanyl patches. So sometimes we have to switch off of it if not only if the patch isn't working appropriately enough for them, or if they feel like they have some misconceptions or have some feelings around fentanyl that they don't want to use it anymore. The long-acting medication that they're on is the fentanyl patch because it's something that stays in your system much longer than quick-release opioids. And the quick-release, we call it instant-release opioid that she was using, was oxycodone, or roxicodone is kind of like the brand name, which is the instant release, which is different from OxyContin because OxyContin is continuous. You can actually see it by the name. The content at the end of the name actually means continuous. So what we had to do is actually come up with the plan on how to transition her off the fentanyl patch and get her purely onto other medications that aren't fentanyl. So we actually decided to switch her purely onto oxycodones. So what I did is that I turned her fentanyl patch, which she was getting about 87 mics per hour, and I converted that into all oxycodone. And if you guys aren't really familiar with switching around opioids, we like to have like this standard kind of a measure or tracking unit called oral morphine equivalents, OME for shorts. Sometimes people use morphine milliequivalents, MMEs, but I just like saying OMEs. And basically what that means is that every single opioid converts back to oral morphine. So they all have like a conversion factor. So what we do is that if we're trying to switch between opioids, we convert everything first into morphine, and then from there we convert that morphine into whatever opioid that we want to do. So for the fentanyl patches, for frame of reference, the fentanyl patches, the lowest I believe they go is to 12, but the one that I use to actually kind of standardize my conversion factors is the fentanyl patch at the 25 mics per hour, which is equivalent to 60 milliequivalents of oral morphine. And we're gonna get really nerdy and really mathy here, but I didn't really think I'd use this much math as a doctor. You know, I did like math growing up, but I was like surprised that since I've been in palliative care, I've been having to do a lot of mental math and a lot of math to kind of convert between opioids. But regardless, the 25 microgram fentanyl patch converts to 60 milliequivalents of oral morphine. So she was on about like 87, or like basically what was it on? It was on a 50, yeah, she was on a 50 patch and then a 12. So what we did is that we just converted all of that into oral morphine, and then we ended up turning her long-acting fentanyl into long-acting oxycodone, which is OxyContin that I was talking about. So the thing about that, though, is that when you're switching between long-acting opioids, the transition can be pretty rough. And the reason why is because when you stop the long-acting opioid, some of it's still going to be in your system, but when you start the new one, which is going to be the OxyContin in this case, there's going to be kind of like that bridge region where it's going to be not covering all the pain requirements that you have. So what we tell them is that if you're having a lot of pain during this transition, rely on your short-acting oral morphines or oral oxycodone for this patient to cover that pain while we're transitioning over. So we like to actually give them a heads up, and we actually told my nurse that was on site with her to let her know, like, hey, I know you don't want to be on this fentanyl patch anymore, but if we're going to convert to another long-acting opioid, it's going to be a rough transition. So just be, mentally prepared for that, because that's how it's going to be if you really want to get off of it. So a lot of pain is not just completely physical. There's this concept of total pain, which is social, spiritual, psychological, and physical. And attacking, why we give a heads up is because we want to attack that more psychological pain component. So if you don't manage that part, it can amplify the physical pain. So that's why we gave a heads up. That way she could be prepared for that. And she appreciated that, because when I called back yesterday to see how she was doing, she was having a rough transition, but she was appreciative that she was aware that the transition was going to be rough. So that was kind of like a nice little exercise for me in terms of transitioning to different long-acting opioids. The thing that I had to kind of consider is usually the fentanyl patches we switch every 7 days, And if you are stopping the fentanyl patch in between that 7K region, then it's a little bit different than if you were stopping the fentanyl patch or if you're about to renew the fentanyl patch. So for her fentanyl patch was actually going to be needing a renewal that same day. So what we did is that we instead had her instead of just having her just replace another fentanyl patch, we had her not do another fentanyl patch and actually start the long-acting OxyContin the same time that she needed to put the new fentanyl patch. And the reason why is because when we stop the fentanyl patch, it's not like you're gonna start feeling the pain coming back immediately. Some of that fentanyl, because it's long acting, is still going to be in your system. So that 12 hours of it still being in your system while you're actually doing the other long acting OxyContin will help to bridge that region. So you don't want to just stop it and just wait for the pain to come back and then start the long acting. You actually want both of them in your system. That way you have some coverage. So that's what I did for her in that moment. If I was stopping, if she was like on say day 3 or day 4, and she wanted to stop it right then and there, then we would actually have to wait a full 12 hours before starting the next long acting, because the other one in the previous method was not completely finishing. So that was just something that I wanted to kind of get some experience about. My medical director and my attendings are giving me the latitude to kind of be a little bit more independent because we are in our last 3 months of our fellowship. So I've been really appreciative, and that's the reason why I chose this fellowship program to match at for my number 1, is because I asked them during my interviews, like, hey, what are your guys' feelings about independence, or how do you guys kind of foster that development of your fellows becoming more independent? Do you actually like to put them in the leadership roles? And they were actually really all about that. Like, hey, like we want you to be in a leadership role, because the longer and longer you go in the fellowship, the more and more that you should feel independent. And it's only a year fellowship, so you're gonna have to be in that role pretty soon. So that is something that I really wanted to prioritize when I was looking for fellowship programs. And that's something that I would recommend to you guys if you guys are current residents right now. If you guys are looking for a fellowship program, ask about things like that, because you don't want to be just in a observing role, because when you're in that observing role and you're not really putting your hands on the ground and your feet on the ground and actually trying things for yourself and making those mistakes when you have that supervision, then you're not really going to feel ready when it's time to graduate and become a solo attending, and then your license is at risk. So that is something that was pretty beneficial for me. I'm about 14 minutes from the actual hospice location where we do our meetings. They do it twice a week, on Tuesdays and then on Fridays, and it lasts for about 2.5, 3 hours. So I'm looking forward to seeing the team again. I haven't seen them in a few months, actually. I think the last time I saw them was at like a hospice celebration. I believe our hospital was celebrating about, I can't remember if it was 55 or 65 years of hospice at our actual institution, which is a huge achievement. That's like decades of achievements. So looking forward to seeing the team. Usually what we do when we get there, after, like I mentioned before, all the nurses and everything kind of divvy up their patients, they give everybody like a list of patients that we're going to be talking about for the day. And we not only talk about their case, but we talk about, are they developing wounds? Are they having falls? Are they having any sort of like lines such as Foley's or IVs or things like that need to be removed? And we talk about the comprehensive care of that patient, because the thing that we really want to avoid, and the whole point of hospice, is that we want them to be comfortable. So are they having anything that's going against that comfort, and how can we intervene on that? So I've seen things such as like managing small new rashes that are coming up, to managing someone that's having a bunch of hiccups, to someone that's having very severe respiratory distress or lung distress because of the whatever condition that they have. So that's some of the things that we're going to be doing. Another cool thing that I actually was talking to one of my nurse practitioners about is that on the inpatient side, we were preparing this patient to go to be on home with hospice, but they actually have a pericardial effusion. And when I first heard the case, I thought she said pleural effusion, but she actually said pericardial effusion. And what that is, for those of you guys that are not in the medical field, is that a pericardial effusion is fluid that, instead of being in the right place is actually surrounding the heart. Usually your heart should only have about 50 milliliters of fluid around the heart, in between the epicardium and the pericardium, to kind of keep the beating smooth. However, if it becomes more and more and more than that, then your heart should be pumping. And if there's heart fluid outside the heart, it's creating extra pressure on the heart. So one, the heart can't beat pretty properly, and then two, your heart can't fill properly. So not only is your heart rate going to be erratic and beating pretty fast, but you're not going to be pumping enough blood and fluid to the rest of your body as you should be. So the case there, they were talking about what to do when they're going on hospice. And right now, whatever you do, whenever you have a pericardial effusion, what you want to do is drain it. So sometimes people go in with a huge needle, go into the heart, just suck the fluid out with a syringe, and then they just squirt it all out. However, sometimes if we expect the pericardial effusion to keep on coming back, which oftentimes with our patients with cancer, they will have recurrent pericardial effusion. So that means that the fluid will keep on coming back no matter how many times we keep on trying to remove it. Sometimes you just leave a drain in there instead of having to use a huge needle and just keep on poking them. So we instead just leave a fluid drain in there. And then what we do is connect a bottle to that drain and just drain it out, kind of like how we do with pleural effusions. But the issue is that the drain that they have is super susceptible to either being accidentally pulled or coming out and causing an infection, which can lead to further consequences of fluid building up, and you don't have a way to get it out unless they get to the emergency department to drain it out. But what they were discussing was whether or not to do a pericardial window, which is essentially a surgical procedure where they put a little bit more of a definitive draining site for that person. But the discussion and the issue that we are having is that to get a pericardial window, it's a surgical procedure. And oftentimes for people going to hospice, they're at the end stage and they're frail. So a lot of times they can't handle the anesthesia needed for a full surgery to do whatever procedure they need to do. So we were actually saying like, hey, I don't know if this person is, eligible to get a pericardial window. I don't know if they'll be able to handle a surgery. But, the cardiologists are ultimately the ones that are going to be doing the procedure. So they're the ones that can either offer it or not offer it. So they actually ended up offering to do a pericardial window, which I'm a little bit worried about because either they could have just went home with the drain and just drained it out, with the risk of it falling out, of course, or they can do a surgery and a procedure, which would even put them more at risk, but it would be a more definitive site. So medicine and interventions is all about risks and benefits, and there's no procedure that you can do that won't have a risk. So it's about weighing the risks and benefits, talking with the patient, seeing if it aligns with their goals and seeing what they want to do, and ultimately they have the capacity and the wherewithal to pick whatever they want, as long as it's being offered to them by the proceduralist. So we'll see how that goes. That's going to definitely delay their discharge and getting home on hospice. So we'll see how that goes. Maybe I'll give you guys an update in the coming days, and we'll go from there. But I'm excited. Other than that, after I finish the hospice meeting that I have this morning, I am going to go back to the hospital to be on the inpatient consult team. Right now I have 3 patients, and I signed off on 2 patients yesterday that ended up being both going into hospice. One of them is going to be going onto home with hospice, and then the other one's going to be going to a nursing home with hospice. And that's something that's really important, is that if you go to home with hospice, you need to have, hospice is not caregiving, meaning that there's not going to just be someone in the home 24/7 taking care of you. So a lot of times you got to either have the family support or hire out-of-pocket caregivers to help take care of you. So if you don't have any of those 2 things, then doing home with hospice is not safe, and we actually have to get you somewhere else where you have more support to help take care of you, and you don't have like an issue such as dying at home without any sort of support or someone to call. Because when you get closer and closer to dying, you're getting more sleepy, you're getting more somnolent, and you're not going to be as in your right mind as someone that is not in that state. So we actually had to send that person to sniff with hospice because they don't have this family support or, the money to hire the caregivers. And caregivers are pretty expensive. I think I was talking to one of these family members, and they can be in the thousands. And it's just something that, not everybody has that luxury to have. So we want to think about those things and ask those questions. Okay, you want to do hospice. Okay, you want to go home. Do you actually have the support to actually go home and do home with hospice? And if no, we need to think about other options. So, it's a lot of things to consider and a lot of things that I've learned this year. It's a lot of, nooks and crannies that you have to iron out. But it's just something that we really want to make sure that we handle, because we don't want to send somebody to an unsafe situation when they could have been safe and well taken care of in the vulnerable stages of their life when they're in that stage of dying. So yeah, it's a lot to consider. So I have 2 meetings today. I have a meeting at noon. We're going to be having a family meeting for a patient about artificial nutrition, about whether or not they want to switch to doing a G-tube versus switching over to hospice, because that patient didn't even really want a G-tube in the first place. And then the second meeting, what is the second meeting going to be about? That one's at noon. I think the second meeting, it's not like an official meeting. I just want to meet with this family for this patient that has metastatic ovarian cancer that is in neutropenic fever after getting a chemo infusion, and is going to be upgraded to the ICU. And we need to have a more further goals of care discussions, because now they're also in renal failure and they're starting dialysis. And this patient is really young, in their like 20s. So this is all a lot. And a lot of these situations for these families that have really young members that are going through such things, it's a lot of, you know, TLC and talking with them and making sure that they're well cared for, because this is quite the shift and we don't expect patients to die at that young age. So having goals of care discussions are quite important, because we want to talk about what are the next things that we can do. This patient's really decompensating. What are their goals, hopes, and worries? And then going from there. So yeah, that's pretty much my day. I'm looking forward to it. That's just some of the information I wanted to share with you guys in terms of my thought process for how I'm going to be organizing this day. And my biggest learning objectives for today is not only to get a good, efficient way of running this meeting that I'm going to be going to right now with the hospice team, but also to familiarize myself with the team, kind of ingratiate myself. I don't know if the team knows that I'm officially hired to work with them, but I might keep that on the back burner for now and just share it later on. But looking forward to it. It's going to be a great day.
They're still checking labs on him? They're still checking labs on him, or? Oh, yeah. Yeah, I feel like I'd rather go back up on the Lasix for him. Yeah, I want to go back. It seems like the edema is like... Yeah, and we talked about that too, and he's like, worried about that. Yeah, just poke something and start bleeding. First one down.
Thank you so much.
Yeah.
Signing all these.
All right, so meeting is officially over. Finished talking about all of our patients. It went really well. This is the first time that I've been here without my attending physically here in presence. They were on virtually kind of watching on Teams. So it went really well. It's kind of simulating what it was going to be like for me when I'm actually in the full-time position here. And it went really well. We talked a lot of troubleshooting for a lot of our patients. We had about, I think, 7 new patients that were being admitted to the hospice team. And it's nice because it provided some continuity for me, because I was just on the inpatient team, or I am on the inpatient team right now. And one of the patients I actually transitioned to hospice. So I saw it from the front end, and now on the back end, we talked about him here. So the nurses that usually see them and, you know, admit them into the hospice services, they usually see them, do a full assessment. But since I already knew from before, I didn't really need to rehash the whole story because I already heard about him. So he's going to be going to a nursing home with hospice, and Then we also talked about troubleshooting for a lot of the other patients. We have the new patients that we talk about and things we need to start or stop for them in terms of medications. And then for the old patients, we kind of talk about how they're progressing and whether or not we can recertify them to be able to stay on hospice. So that went really well. I was kind of troubleshooting and asking the right questions and getting a feel for how the flow is going to be. And your mind is kind of drawn and pulled away in many different directions because you have a bunch of papers to sign and paperwork to like actually push through. So I have to be kind of like keeping an open ear and then also filling out paperwork, and then also have like my laptop on the other side to be looking through the chart and kind of verifying everything that's being told to me and looking at the medication list, and just it's like I'm doing 3-4 things at once. So that's a little bit of an adjustment for me, but I kind of like that because I had to stay on my toes and had to keep a keen ear to what the nurses were telling me throughout the meeting. So I thought it went really well. I'm about to head back to the hospital, fill up gas at Costco. Thankfully, the Costco is right next to this hospice building. And then I'm going to drive back for my meeting at 1, try to see a patient in the inpatient setting and, write a note on them because one of them is decompensating, unfortunately, and they're pretty young. And we'll go from there. And then later at, I think around like 2 p.m., we actually coordinated to do a face-to-face visit virtually, which is a new thing that they're allowing for us to do on hospice. So we have to do these face-to-face visits to actually see and visualize how the patient is doing. We can see all the data points that our nurses put in, but the MD or the physician needs to be able to see them, and that doesn't need to be physically in person. That can also be virtually in person, which is a new change with Medicare. So that's something that's really helpful and will really help for efficiency's sake, because some of these places that we have to see our patients are very, very spread out. So being able to make every single appointment, it can be pretty time crunching. So being able to do things virtually is a huge major shift, and I'm glad that's being initiated before I actually take the full-time position. So that's what I'm going to be doing at 2 p.m. And then, yeah, I think that's what the plan is looking like today. So I'm pretty excited. Let me actually head to the gas station and get things moving.
Bluetooth connection success.
Let's start with Stotts, who, is longtime head coach, very qualified to be a head coach.
Hey, boss. Good, how are you? Main hospital?
It's okay. Thank you for helping facilitate this conversation. Just kind of give us a picture of what's going on.
Of course.
So we can check in.
Yeah, we'll sign off for now, but we'll be watching in the background. And that's all she wrote.
Are you back next week?
I'll be on hospice next week.
Oh, okay.
Yeah, but I'll be around. I'll probably be on the inpatient side as well. I'm going to wait for this face-to-face to be sent to me so I can fill it out. And I think they're in a meeting right now, so I'm like, might as well just beat the traffic.
Hey, man.
Hey, what's up?
So there'll be 2 things that they send you.
Mm-hmm.
One is like the face-to-face attestation,
Mm-hmm.
and the other is like the research, like CTI.
Mm-hmm.
So the face-to-face attestation, all you have to do in that one, it's already like pre-populated, and you just kind of put whatever kind of physical exam you did over video.
Mm-hmm.
It could just be like they're alert, they're not alert, they, are not in distress, the respiratory, seems X, Y, and Z, they're speaking in short or moderate length sentences, stuff like just doesn't have to be anything specific, just the whole point of the face-to-face attestation is that Medicare thinks we're lying about doing a face-to-face. So they want, just some type of documentation that you actually saw the patient. So,
All right, I'll let you know if I have any issues.
I'm sure there will be an issue. just let me know.
Okay. All right. Thanks.
All right, man. See ya.
Bye.
All right, so we are finishing up the day. I just wanted to give this last little bit of insight of something that I learned today and something that I did today. I ended the day off pretty busy. I had 2 back-to-back meetings. One of them was having a ethics discussion for whether or not to transition a patient to hospice or get a PEG tube in someone that's unrepresented. So that's a little bit of a complex situation. So it's gonna take a lot of time to figure one out. And the second one that I actually had was determining what a time-limited trial means to a patient. So for a actual goals of care discussion and on the pulse, which actually, let me go ahead and grab a pink pulse for you guys so you can see what I'm talking about. On the pulse, you can actually fill out a time-limited trial, which essentially means that you want to give a certain amount of time to determine or not whether a intervention is working for you or not. So I actually have a pulse right here you guys can see. So let me go ahead and pull that back over here. But on there, time-limited trials means something different to everyone. And for our situation, we had a patient that marked that they wanted a time-limited trial for artificial nutrition, whether it's through like an NG tube or through a PEG tube, which is going to be placed in the lower abdominal region. And they didn't actually put specifically what they meant by a time-limited trial, which is why documentation is so important whenever you're doing a pulse or some sort of change in their overall code status. Because if you put a time-limited trial, that means something different to everybody. So does that mean a trial of a week, a trial of a month, a trial of a year? We don't know what that means because you guys didn't actually put that into the documentation. So we actually had a family meeting with a family member to determine what they thought a time-limited trial actually meant. And neither of them were actually present at the time that he actually filled out one of these pulse documents. So it wasn't that hard of a family meeting because I think the context of that patient's admission probably didn't align to what he was thinking when we were thinking about a time-limited trial when he filled out the pulse. The circumstances were a little bit different. So we ended up doing a time-limited trial of about 2 more weeks of artificial nutrition with this current regimen. And if that doesn't work, then they gave us consent to transition to a GJ tube, which is kind of a different location to where the PEG tube is placed. So those were 2 pretty good discussions. We ended up finishing up those meetings, and then I did a face-to-face. One of the things that I mentioned earlier is that we can actually do face-to-face visits for hospice through video visits. So it was actually quite convenient because I had a lot of work to do at the hospital, and the face-to-face visit would have had to be maybe 30, 40 minutes away. So having to do those meetings at the hospital and then driving and rushing during rush hour of all times would have been very difficult. So I'm glad that they're allowing us to do video visits for hospice. So this is a patient that had end-stage Alzheimer's disease, and they've been on the hospice team for quite some time now. And the longer that you're in hospice, the more stringent and strict you have to be for determining whether or not someone is still hospice eligible. So we had to be very specific in saying, what sort of declines are you having? Are you having your mean arm circumference, meaning right here? A lot of times for patients that are flat and not getting up a lot of the times, they can't get up and do an actual weight. So they measured this area to determine whether or not you're losing weight. And if you are able to stand up and we just measure your weight, some other things that we can check is how many hours out of the day are you actually sleeping? And the reason why we do that is because the closer and closer you get to death, the more hours out of the day that you're actually sleeping. So this patient actually was sleeping about 20 to 21 hours a day, which is whoa, that's a long time. And some other things that you can actually see is your symptom burden. So are they having more refractory symptoms, pain, shortness of breath, nausea, vomiting, things like that? You can actually check for their palliative performance scale. So their functional status, essentially, are they more bedridden? Are they someone that's a little up and about, so they're still able to do things? Usually when you're in the hospice category, your PPS is less than 50%, which is you're mainly in bed all the time and barely able to get up. And that's something that we can trend as well. And then some other things that you can check as well is the amount of food that you're eating, as well as, what's another thing as well? The last thing you can actually check, I cannot exactly remember. Oh, your level of consciousness. So are they just someone that's just not really, clear of mind the whole day? So those are a couple of things that we had to actually stringently check to see whether or not they were still declining. Because if they weren't still declining, they're actually getting better, then hospice actually doesn't fall within their goals of care, and they actually are not eligible anymore. And we have to I don't like the word revoke, but we basically have to transition them off of hospice. So that was a discussion we had. It was nice, maybe 20 to 5 minute talk that I had with them over the video visit on Microsoft Teams, which is pretty cool. And then the last thing that I had to do, I had one more patient, or before I actually got to that patient. So after we do a face-to-face visit, we have to do two different things. A face-to-face visit documentation note, where we have to write everything that we observed to kind of prove that we actually observed the patient and saw the patient, and then document what we saw. And so we signed that, which has to be done 30 days, or at least 30 days before the certification time period is. So the time periods are 60 days, 90 days, and 90 days from then on out. So at the 30-day period before whatever that 60-day mark or 90-day mark, we have to make sure that we do one of those face-to-face visits. And then for the certification of terminal illness, that's basically a documentation note noting that we actually certify that a person is still hospice eligible. We have to do that 48 hours within their admission into hospice, and then at those same time periods, the 60, 90, and 90, we have to sign a certification of terminal illness. We call them CTIs, at least 15 days before the actual period expires. And it's a huge issue if you don't actually do it in time, because then you have to start paying for a lot of extra things through the insurance with the hospice agency. So that's kind of a big dripping of a lot of money that can go and help our patients. So those are the two things that I actually signed. In the CTI, that's basically another certification note, and you're writing the primary diagnosis, so it'd be like Alzheimer's, and then the secondary and unrelated diagnosis. And the reason why it's important to sign those things and be explicit what those things are is because for your primary and secondary diagnoses, which is why we think you're actually declining and getting closer to death, which is why you actually are in hospice, any sort of medication that's associated with those actual conditions, the hospice agency pays for. So it's actually important what you put in those categories. And then the last thing that I did today is that I saw one patient for another hospice admission. It's very hospice heavy this week, I noticed. I actually had a patient with end-stage liver disease with decompensated cirrhosis, and we actually had to transition them to hospice because they were starting to have a lot of refractory symptoms. So they were having a lot of ascites that had to be tapped every couple of days to weeks. So ascites are basically fluid that just builds up in the abdomen. So they actually had to drain that fluid repeatedly. And I actually recommended for them to do a peritonic drain, which is instead of having to go in there and have to drain all that fluid and poking them all the time with a huge needle, we just put an indwelling drain there to pretty much allow them to just connect a bottle to it and then turn on the faucet and just allow the fluid to come out of there to drain that ascites, because ascites, if it gets big enough, can be very distressing to a patient and cause a lot of pain. So that's one of the things that you can see that is one of the categories for what can determine whether or not someone can get into hospice, is if their ascites is refractory to a bunch of different paracenteses. And then the second thing that you can do is, do they have a history of a variceal bleed? And that's basically a bleed that's coming from your esophagus or like the abdominal region. Usually it's from the esophagus. Usually the liver has to clear out a bunch of toxins and is a huge area where blood is filtered. So if your liver is scarred down, it's hard for the blood to actually go through the liver, and instead of going through the liver, it backs up and it goes into all the veins that are all throughout the body. So a major region or that we get worried about is the esophagus, and the veins in the body are not actually created to handle that much pressure. So that backup of pressure that goes into the veins can lead them to be susceptible to popping and causing huge, massive bleeds. So if you have a history of a bleed in the past, you actually have a pretty poor prognosis. And usually people that have a bleed in the past from a variceal bleed, I think they have like a 50% mortality within 2 years of that bleed. So it's pretty high. And the other things that we look out for, do they have hepatorenal syndrome? So kind of same concept with the actual variceal bleed. Blood pumps back into, or pumps away from the actual kidneys. So the kidney actually can't do its job, and you're starting to go into renal failure and may need dialysis. And usually dialysis doesn't help for hepatorenal syndrome. And then the other things that we look at for are refractory hepatic encephalopathy, which is basically confusion that comes from the metabolites that are building up from the liver that cause you to be confused. So usually there's 4 stages of hepatic encephalopathy. Usually 0 means you're not confused at all. 1 means you're having a sleep-wake reversal. So usually you're more awake during the nighttime and then real sleepy during the daytime. Level 2 is that you start getting a little bit more confused. Step 3 is that you're usually more lethargic and you're like, it's really hard for you to wake up, but you are able to wake up. But stage 4 is that you're completely comatose. So those are the 4 different stages of hepatic encephalopathy. So when you say refractory, you're starting to get into the more stage 3, stage 4 region, and everything that we try to do, whether it's lactulose or rifaximin, to try to get you to poop out all those toxins that are building up from the liver, it's not really working, and that's a stage that or a sign that you're getting closer and closer to dying. So with this patient that we had today, and then the other thing is that you can have something called spontaneous bacterial peritonitis, which is basically an infection of the fluid in that ascites that we talked about earlier, which is a really bad sign and could be close to them actually passing. So we go through I went through their entire chart. He actually ended up having refractory ascites, so I recommended for the team to get a peritonex drain. And then he actually also has hepatic encephalopathy, not refractory, maybe like around stage 2, but he does have a history of SBP, which is actually why he was actually in the hospital, the spontaneous bacterial peritonitis. And I don't believe he had hepatorenal syndrome, although his kidneys aren't working that well right now. But those are the 3 things that he was seeing. He had like 3 hospitalizations this year and has been to the emergency department like 9 years. So those are all signs that like he's not really doing too well. He lost like about maybe 40 pounds in the past year and has also not really been eating too well. So these are all signs that they're declining and declining and declining in the family. And he actually wants to prioritize comfort. So with all those things, that kind of aligns with hospice care. And I actually had to do a kind of educational session for the wife, because they thought that hospice was you send someone somewhere for them to just die, and they thought that we don't do anything in terms of providing comfort or medications or that nature. And that's one of the things that I actually do all the time is get a perception from the family. What do you think hospice is? What do you think their philosophy of care is? What do you think the intention of hospice is? And if there's any gaps or any things that are incorrect, then actually take that moment to actually correct it for them. That way they don't go into hospice or refuse hospice because they think it's something else that it's not is. So I actually had to do that with the family member, and they actually accepted to do hospice, and they're going to be getting discharged on hospice after they get that peritonex drain place. So a pretty busy day, to be honest. I think I left a little bit later than I usually do, but later in the palliative care sense is usually like 5:30, something like that. I left around maybe 4:45 on the dot. Usually I'm a little bit more efficient than that, so I usually leave a little bit earlier, but still, otherwise, it was a pretty busy day, really successful day, and then next week I'm going to be on hospice, so I'll give you guys that experience in a vlog like that next week. But other than that, I hope you guys enjoyed the video. Let me know if you guys have any questions down below. It was a pretty educational day today, and I'm looking forward to the rest of the year. I actually was looking at my schedule right now, and I have kind of like a list of things that I do to kind of cross things out. Let me take it so it's not just tracking my face, but you can see there I have like my schedule, and I actually cross things out as we go. So I have one more week for block 11, and then after that I'll only have 2 more blocks left, which is exactly 8 weeks left of the actual fellowship. And one of those weeks I actually switched to be my vacation week. So technically only really have 7 weeks of the program left after next week. So looking forward to it. There's a lot more to come. Comment down below, like the video if you haven't already, and I'll see you guys later. Peace. Have a nice day.